A very warm welcome to all of you. Today is going to be a lecture on the development of treatment strategy. So basically in today's lecture, you will be learning about the factors which influence the treatment planning and how to go about with multidisciplinary approach for treatment planning. So this is basically the kind of treatment which you will be performing in the Department of General Dentistry, and I'm sure you're all already aware of the different phases of the treatment plan which already exist, which you have been recording in the Department of OMR in year 4. So basically this is a summary of the case history chart which we follow in our college. So how is it that you start when the patient walks into the college? So basically you greet the patient, exchange introductions, and you make the patient a little comfortable in the chair, and then you ask the patient a few questions. Yeah. What brings the patient to the clinic, or how you can be of assistance, so on and so forth. So basically you take the consent from the patient saying that you are now going to be treating the patient, and you're going to be first asking a couple of questions and creating a kind of a chart which the other doctors can use to assess the treatments which are required. And of course you record the chief complaint in chronological order and in the patient's own words. Patient's own words, of course, for medical legal considerations, and chronological order, so that you can treat the patient according to the need or the dire need of the situation. Then of course you have to elaborate the chief complaints. So like if the patient is complaining of pain, you of course have to elaborate the reason for the pain, the whereabouts of the pain, that is the location, the intensity, the reason behind it. Is it getting aggravated on doing something? How is the pain relieved? Is the patient on any medication? So on and so forth. So that comes under your history of presenting illness, where you are basically just elaborating the chief complaints which you have jotted down. Then of course you take a brief medical and dental history about the patient, so you get to know a little more about the patient in detail. So you inquire about the patient's medical records, whether the patient has been hospitalized in the recent past, or whether the patient is under medication for any condition, or whether there's any underlying systemic factors, etc. And of course the dental history is to figure out whether the patient has gone to the dentist before. If yes, then what kind of a relationship did the patient have with that dentist is very important, because you can actually judge the attitude of the patient, whether the patient is easygoing, whether the patient is educated, whether the patient is interested in getting the treatment done, and how the patient forms a relationship with the dentist. All of that can be evaluated with the dental history. Then of course after your history taking sessions are over, you of course go on to the clinical examination. So that of course is divided into your extraoral and intraoral. So in the extraoral you check for your facial asymmetry and the fullness of the lips, the competency, and so on and so forth, whereas the intraoral deals with the hard and soft tissues. After you are done with your entire clinical examination, then of course you have to arrive at a diagnosis. So to help you with this diagnosis, you have certain diagnostic aids. So you have radiological tests, like the most common being the IOPAs, and then of course you have your thermal tests, to determine the vitality of the teeth. So you have your hot test, you have your cold test, you have your electric pulse tests, so on and so forth. So these help you to formulate a diagnosis, and based on this diagnosis you are going to be offering the treatment plan to the patient. So of course we never give only one option to the patient, we always give a set of options, and we always ask the patient to come on board, so that we know that the patient is also involved in the decision making process, so that the patient also feels that he or she is not let down totally, and he or she is aware of what is happening, and he or she also has a role to play in the treatment which has to be taken. Of course you have to understand that good health and optimal function are to be addressed primarily, and only after both of them have come to normal, that means you are able to achieve good health and optimal function, that is your mastication and occlusion, only then you concentrate on adjusting the appearance, that is the aesthetics of the case. Coming to the different kinds of factors which influence your treatment plan. So these are the patient factors. So what does the patient expect from the treatment? Whether the patient wants to get low cost treatment, whether the patient wants to get high cost treatment, does the patient want to save the tooth, does the patient want to retain the tooth, does the patient want a removable prosthesis, fixed prosthesis, no prosthesis whatsoever, etc., has to be determined. What is the patient's attitude towards risk? Now, certain dental procedures do carry uh, a certain amount of risk. So, if the patient is too scared or apprehensive, he or she may not be totally on board with that sort of a treatment. So, you have to prescribe the treatments accordingly. So, if the patient is very apprehensive or very anxious, you may not want to do too much of invasive procedures. You may want to do the palliative and the prophylactic kind of treatments first, so that the patient can get a chance to calm down and get familiar with you. And then of course as over time the patient develops a sort of trust in you, and the relationship grows stronger, then probably you can go on to the more invasive procedures. What are the patient's concerns? Does the patient prefer the silver amalgam fillings, or is the patient more into aesthetics? If there are broken restorations, does the patient care about getting those restorations replaced? Is the patient suffering because of any problems in the oral cavity? All of this has to be determined when before you formulate your treatment plan. All of this actually plays a role in formulating your treatment plan as well. Then the social history, it affects the attendance pattern. So if you see that the friends around the patient or the family members around the patient are regular dental checkup kind of patients, then of course he or she will also be obliged to come. He or she will not be afraid to come to the dentist. If the family members are apprehensive and scared, that fear of the unknown will obviously be transmitted to the patient as well. So that of course affects the attitude of the patient towards receiving dental treatment. Then of course you have various kinds of habits. These are the deleterious habits like smoking and betel nut chewing and tobacco products, which of course limit your treatment options and of course limit the extent of recovery of the dental health as well. The medical history. So if the patient has underlying systemic factors, yes, it does play a role, especially when you are dealing with infections in the oral cavity, and you want to prescribe medications which help in the healing, or which accentuate the healing process. If the patient has an underlying medical condition, then of course the healing is going to be delayed, or who knows, maybe that you have to be prepared that if the medical condition is being treated by medications, what if those medications are going to interact with the medications that you are going to prescribe? So everything has to be taken into consideration. And yes, a major role is also played by the cost. So if the patient is not well to do, you have to show a little bit of consideration. You cannot expect the patient to go in for the highest cost treatment. You have to give a little bit of consideration. You have to give out the various options possible, and if possible, show a little humanity, and maybe reduce your treatment costs a little bit also, so that the patient also feels that there is humanity left in the world. Then of course you cannot go out of your way, because after all you do have to set up your practice as well. Now coming to the dentist factors, the clinical experience comes with time. So obviously if you've just stepped into the dental market and you set up a clinic, you cannot expect to be doing better than a person who has set up the clinic 15 years ago. Obviously that dentist has worked very hard over time and has experience on his or her side. So clinical experience will come with patience, with time, and with hard work. And of course your communication skills, they have a very very important role to play. If you are polite to the patient, if you lend a good ear to the patient, so that the patient can express his or her troubles or complaints, and you are patient with them, you are kind to them, half the battle is won, because you would have gained a good patient and good advertisement as well, because this patient is going to go and speak only good about you to the other patients or other friends of his who are potential clients for you in the future. Coming to the risk assessment, so every individual has different attitudes to risk. This is what I was saying in the previous slide. and some may be prepared to try a novel technique which has little scientific evidence. So there are certain techniques which may not have been documented in the olden days, but with evidence-based dentistry, you're seeing in day-to-day lives that a lot of dentists are using it. Now, of course, it is your duty that you have to explain the things to the patient. You have to say that yes, this is a new concept and it is gaining popularity, but I do not have the evidence to back me up. Clinical trials haven't lasted for years, so there is a certain amount of risk involved. So you have to assess whether the patient is actually going to be on board with such kind of or not. Now, coming to the clinical factors. So the simplest example is when you have to decide whether a tooth has to go for restoration or extraction. So you have certain criteria which have to be judged. The first is, for example, is the remaining tooth, the coronal structure. So you have to decide whether, in the long term, what kind of a patient is it? Is it a patient who is going to be maintaining good, impeccable oral hygiene, or is the patient, going to be careless, not going to be taking care of the prosthesis in future, and is not going to be taking care of the prosthesis in terms of mastication, is going to be careless or reckless with chewing habits, or with deleterious habits like smoking and tobacco chewing or tobacco sniffing. So all this have a major role to play when it comes to safeguarding the life of the prosthesis. So all this has to be evaluated. Subgingival caries. Now, subgingival caries has to be treated. It's not very easy to treat. Is the patient going to be willing to get the treatment done? And if so, if the treatment is done, if the oral hygiene is not impeccable, it can lead to failure of the restoration, and it can also lead to failure if, as a clinician, you have not done the proper isolation, because it's subgingival. So isolation is going to be key, and you have to choose a suitable restorative material to do your subgingival caries restorations. All this plays a role. Certain teeth, endodontic treatment, is it possible? Is it going to be complicated? Is the long-term prognosis okay or not? It depends upon the complex root canal anatomy, sclerosed canals, if you have separated an instrument, so on and so forth. So all of this have to be taken into consideration before you can actually proceed with going to save the tooth, or when you decide that in the long term it will work out better if the patient just gets rid of the tooth and then is replaced with a prosthetic one. You have to judge the bone support, whether it is adequate enough to support the prosthesis, or the tooth is already mobile, grade 2 mobile, and it's best to get it removed, and then you can go in or advise for suitable prosthesis later on. Okay, and then coming to the treatment plan and its sequence. So of course you all know the first is the emergency phase. So this is the most important one. So if the patient is in severe pain, you obviously cannot send the patient back until you tend to alleviate the pain, or tend to help the patient out in some sort of a way. So emergency access openings are a good example. Incision and drainage for abscess cases, and extraction of hopeless teeth in which the patient is having severe pain. However, extractions when the patient is having pain, nowadays we prefer to keep the patients under antibiotic prophylaxis before we actually go in for an extraction. This is because if the tooth is sound and it has good bone support, if there is an infection, the reason for the pain is going to be an infection for most of the cases. So if there is infection, there is a good chance that the patient is going to have a more amount of pain even after extraction of the tooth, and it's going to be difficult to manage the tooth in pain also. The anesthesia may not be that profound as expected. So it's good to advise the patient one round of antibiotics, get the pain under control, and then the pain and the infection under control, and then proceed with your extraction. So it's there are two schools of thought. Both are being practiced in different areas of the world. Then coming to your initial and diagnostic phase, this is more like a prophylaxis kind of a phase, where you keep the plaque under control, you do your oral prophylaxis like scaling, root planing, and curettage, fissure sealants for deep fissures, fluoride application to protect the teeth from future caries attacks. You assess the oral hygiene index, you assess the diet of the patient, you control the diet, monitor the diet, advise proper diet counseling. If the patient has any deleterious habits like smoking or usage of tobacco products, then you have to advise the cessation. Of course, smoking cessation cannot be done in a day. As you all know, it has to be tapered. Otherwise, the patient, if he or she is a chronic smoker, they will have withdrawal symptoms, if you are told to stop it abruptly. So you have to taper it gradually over a period of time, and then of course you have to advise the cessation altogether. Coming to the stabilization phase, this deals with the restorations of the decayed teeth which are beyond repair. The restorations of decayed teeth and teeth with cervical abrasions. The extractions of teeth which are beyond the repair of the dentist, and which you feel the prognosis is hopeless. So you extract them. Of course, you also have to extract the impacted teeth before they actually create problems for the teeth which are already erupted into the oral cavity. Your endodontic treatment also comes into the stabilization phase. So you have to do the root canals of infected teeth and or teeth which have been affected due to trauma. You have to give them provisional prosthesis like immediate dentures, so that the patient does not feel aesthetically inferior, so that the patient has a replacement immediately after the extraction as well, and the extraction site can heal under the area of the prosthesis over the next couple of weeks. Then of course you have your non-surgical perio treatment well in the stabilization phase. In the definitive phase, you have to reassess the oral hygiene of the patient and see what is necessary to be done. All your gingival surgeries come inside the definitive phase, like your depigmentation or your flap surgeries, frenectomies, etc. And of course your final prosthesis. So whether the patient is getting a single crown, fixed partial denture, removable partial denture, so on and so forth, and implants as well. Now the maintenance and the recall phase, although this looks like it's a very small piece of paper, it is actually one of the most important, because this is the way that you actually send the patient off from your dental clinic in a formal manner. So you have to reinforce oral hygiene, and you have to recall the patient every 6 months. It can be at every 3 months also if the caries risk is very high. So for high risk patients, the recall can be between 3 to 4 months, or else if the oral hygiene is good and the patient is the patient compliance is good, then recall every 6 months should be fine. You have to, and during the recall you have to monitor the restorations which you have done, whether they are fractured, whether there is a secondary caries attack, whether they are intact, and of course you have to review the prosthesis also, which you had given in the earlier appointments, whether they are retentive enough, whether the prosthesis is broken, do they require repair, so on and so forth. So what we have here is a clinical case scenario. It's just for the understanding of how you have to do your multidisciplinary approach. So this is what is commonly practiced in the Department of General Dentistry. So now that you're in year 5, you'll be coming across these kind of scenarios commonly. So the patient is a 31-year-old male by the name of Stephen, who works as a laborer. So he wants to face up to the dentist after a previous bad experience. So the patient is very apprehensive, and he was so scared of coming to the dentist that he extracted 2 of his own teeth with using pliers. And he was an aggressive smoker. For 15 years he smoked 20 cigarettes a day, but he gave up 8 months ago. So he's trying to quit. So he's been sober also for 2 years. So he's abstaining from smoking and alcohol, and he is separated. So he is a divorcee and has a young son. And the presenting complaint is that Stephen was hit in the face approximately 1.5 years back, following which he noticed that his anterior teeth were mobile. So he has come to the dentist with generalized low-grade pain from all areas of the mouth. The medical history: the patient is fit and well, he has no allergies and is not taking any medication from the doctor. So how are you going to go calculus, inflammation of the gingival tissues, and the missing teeth as well? The caries has been recorded. Of course, we are using the ICDAS system, and the patient is partially edentulous. So the patient wishes to improve his aesthetics and replace his missing teeth. So these are the patient's expectations. So once this is in mind, now you have to formulate your treatment. So your treatment plan, the aims are the oral hygiene has to be improved before you deliver the process, of course, otherwise your prosthetics is going to fail. So oral prophylaxis, oral hygiene instructions and other preventive advice has to be given. All the carious teeth have to be restored. The root stumps have to be extracted along with the teeth which have hopeless prognosis. So if there are teeth which are grade 2 or grade 3 mobile, they also have to go, or if there is inadequate bone support, it's better to get rid of them. Then of course you have to fabricate and deliver your final prosthesis. And since the patient has already stopped smoking, it is best to get him to go to a smoking cessation counselor to remove the risk of further going back to that habit in the future. Yeah. So what is the initial treatment phase? The initial stabilization and diagnostic phase, you do your supra and subgingival scaling. Maybe if not in the first appointment, at least over a period of 2 appointments. You assess the oral hygiene index. You advise the patient on the diet plan and the nutritional assessment. And of course, you have to encourage the patient. So you have to say that we appreciate the fact that Stephen is actually, taken it upon himself to stop smoking, so he has to continue with that. He shouldn't give in to a weak willpower. And then of course you go on to your restorative phase. So you have to restore all your carious teeth with composites. Now you have to remove all your root stumps or retained roots, so all of them have to be extracted, and the teeth which are grade 2 mobile, they have to be extracted as well. And you have to fit your immediate dentures, so that of course it is for aesthetic reasons, so that the patient does not feel like he is edentulous in some area. You have to decide whether the prosthesis is going to be acrylic or whether it is a cast partial denture. And then of course the maintenance phase, this is your recall phase as well. So you reinforce your oral hygiene instructions and the diet advice every 6 months, and you have to keep counseling the patient for the smoking cessation, keep encouraging him so that he does not go back to the habit. Keep monitoring the caries risk assessment of the patient, monitor the existing restorations, whether they are fracturing or whether there is secondary attack or whether they are getting discolored. And of course you have to keep reviewing. So in this case, if the patient is a high risk patient, so initially you can recall the patient every 3 months, and once the patient is on track, you can probably do it biannually. Now coming to your evidence-based dentistry. What is evidence-based dentistry? It is the practice that integrates the best available evidence with clinical experience and patient preference in making clinical decisions. So although this may not be something which you have read about, it is something which you have been doing ever since you have entered the clinics of your dental college. You are actually you're actually going to your lecturers with your doubts when you see a patient or when you're about to treat a patient. And of course the lecturer is going to be prescribing the most appropriate form of treatment, which is either given in the textbooks or which is the treatment of the hour in the present day scenario. So that of course is nothing but your evidence-based dentistry. So this is what you will be practicing also in the clinics. It is aimed at general dental practitioners to help achieve the best available evidence on the latest developments in various aspects of clinical dentistry. And it is also an invaluable tool for the specialists needing to maintain an awareness of new approaches outside their branch of dentistry. So this is one way of keeping yourself up to date as to what is happening in the present world. And what to look for. So when you are treating the patient, this is you have to check whether there is any change in the medical history or the social history of the patient, because your treatment is going to vary. Look for any changes in your hard and soft tissues, your periodontium, the restorations. Keep checking or assessing your patients every 3 to 6 months depending upon your caries risk. So you have to do your radiographic follow-up also of your endodontic teeth. Monitor your periodontal disease also radiographically using bitewings or the OPG. And okay, so this is the assessment of the recall. This is what I was telling you about. You have to recall the patient every 3 to 6 months depending upon the caries risk. So how do you assess the caries risk? I'm sure you all have seen this the single page which is there in the case sheet when you have been taking cases, recording cases in the department of OMR, oral medicine. So you ask for the past caries experience, you ask for the social and medical history, the dietary habits of the patient, the sugar intake habits, the use of fluoride supplementing agents, how is the oral hygiene, whether there have been any new restorations in the past 36 months. How do you feel the saliva is, whether the saliva is thin, thick, which also affects the caries risk of the individual. So like I said, the low and the moderate risk patients, they can be recalled every 6 months, and the high risk, of course, it is best to recall every 3 months. And once the patient is converted to a moderate or a low risk, then of course you can go biannually. So a low risk patient is one who has no decayed teeth in the past 2 years. There is no demineralization of the tooth and no visible plaque. And the high risk are patients are those who have decayed teeth in the past 2 years. There is enamel demineralization in more than one specific area of the oral cavity, and caries is visible. You have visible caries affecting the enamel and maybe the dentine also, and of course you have plaque and calculus also. So in those cases, you have to recall the patient every 3 months after doing your treatment, just to monitor their oral hygiene status. Tooth wear. So what is tooth wear? I'm sure you're all aware. It is the wearing away of the tooth. So you have, it could be because of attrition, abrasion, erosion, or abfraction. So before you treat the tooth wear, you have to find out why it's happening. So you have to get to know about the etiology, and if it is because of parafunctional habits like bruxism or night grinding, you may want to consider giving a splint. So in this case, the splint is nothing but your occlusal guard, or your so that the patient does not grind his or her teeth. You have to continuously monitor the patient, probably initially every week or every 2 weeks, and you have to create study models and collect photographs to assess the rate of wear, so that even the patient is aware whether it is progressing, digressing, or it is stationary. And of course you have to motivate the patient, and you have to play a role in the encouragement of oral hygiene practices, and measure it as well. Now this is what I told you before also regarding the recall. So it's between 3 months to some places they say it's 1 year, but we all prefer it if the patient comes to us biannually. Easier to keep a track on the patients. And yeah, so coming to how you're assessing the crown and bridge work, you have to check for the oral hygiene status of the patient. You have to check for the cementation, whether it's heading into failure, or whether the prosthesis is not mobile, whether the porcelain has chipped off, or whether there is general wear of the prosthesis. Coming to the identification of the patient needs, so basically you have to correct the existing disease which is present in the patient's mouth. You have to prevent the cropping up of the disease in future. You have to restore the function, and only after the restoration of function do you have to play a role in the improvement of appearance. So once the function has been restored, yes, you do address the aesthetics, because in the present day the patients are very, very worried about their aesthetic appearance as well. Okay, so that is about it for today's lecture. So I hope it has been informative and useful for you. If you have any doubts, or you need any clarifications, please feel free to contact me or post in the comment section below. Okay, take care everyone. Stay safe. Hope to see you guys soon.